Okay, I think everyone's been admitted who's waiting. And so I guess I'll get started. I'm Rebecca Adams, and welcome to the Gerontology Research Outreach Workforce Development and Teaching Hub, Lunch and Learn. I apologize, I am pink. I don't know how to deal with that. It's been an ongoing problem during these Zoom meetings. But this is not my normal complexion, just so you know. We're very pleased today to have Deborah Lekan here to present on her research on frailty. And she and I were just talking. Deborah, until recently, was an assistant professor in nursing, but she's beginning to gradually change her identity. And although she'll be continuing to do her research, she's going to be cutting back on her teaching at UNCG. And so we're delighted we could get her to present while she was still a full-time employee, and to take advantage of her expertise in this area. Deb has been an active member in the growth network before it was, even from the time before it was called that. And we've really appreciated her engagement and hope she'll continue to remain engaged in the network once she finishes up her research grant through UNCG. So I think we're good to go. Anything else you want to say before you get started?
First, just mainly to thank everybody for being here, for taking time out of your busy day on this gorgeous day. And this can be as pretty informal. So I'll talk about frailty and some about my research, but feel free to jump in and ask questions, offer comments and insights. And it's a topic I'm very excited about and happy to talk about, but I will sort of aim to kind of show a laser beam on kind of what is happening in my work with frailty in the context of aging demographics. So I'll go ahead and launch my screen. And let's see. Okay, great. So can you all see that okay? Perfect, thank you. So just as an introduction, I am a certified gerontological nurse. I've been involved in gerontological nursing for, my initial certification was in the earliest class of the American Academy of Nursing certification exam in the early 1980s. And so I've been very keen on what has evolved in aging and geriatrics, and in particular frailty. And frailty became an area of interest because as time went on and as people lived longer, it seemed like this was the ultimate geriatric syndrome. We think about and understand the geriatric giants, right? Delirium, falls, incontinence, pain, but frailty seems to be, to me, an uber syndrome in that it kind of incorporates all sorts of vulnerabilities in a total sort of manifestation of risk. And so I saw that as being quite intriguing. And so I began in looking at the literature in my earlier investigations to see what was happening in frailty. And a lot of what was happening in frailty was in the community, looking at community level older adults and manifestations of frailty. But as I explored further, I saw that one area of investigation that had not been pursued much was frailty in the acutely ill, medically unstable, hospitalized older adult who is under the more extraordinarily intense stressors of not only their complex medical problems and medical instability, but also the hazards of hospitalization and the risks that go along with being in the hospital. And so I began to look at ways to develop a frailty assessment tool that would help capture those high-risk individuals who could benefit from targeted interventions, and as well identify who is not at high risk, so we can spare them from, so we can carefully stratify and triage those individuals. So today I'll be talking a little bit about some general notions about frailty, some of the widely used tools, how my work evolved in that context to identify a tool that could be used with existing electronic health record data in the hospitalized context, and then look at kind of what we learned and where we're going in terms of future research. So I like to start by talking about and asking, what is frailty? And when I teach gerontological nursing to the students, the undergrad students and the RN to BSN students, it's interesting about the perceptions of frailty. Both practicing nurses and people on the street, lay individuals will say they know it when they see it. And this is something geriatricians will say also. It can be difficult to quantify, but in some ways there is a phenotype. There are certain physical manifestations that one thinks about with frailty. There's the concept of the frailogram, which is identifying frailty from the foot of the bed, and any clinician knows how that works because you have to quickly synthesize information. But what I understand about frailty is what's under the covers, what's beneath what you see. And that would be somebody who otherwise looks well, maybe even medically not unstable, but has a tipping point that's more at risk and with less compensatory reserve than someone else in equal situation. And so there can be frailty that's underlying that would only need a few factors to create increased vulnerability. Hospitalization and the things that go on during hospitalization are some of those factors that I think not only make existing frailty worse, but can propel someone into frailty during hospitalization. We are very familiar with the aging demographics, but the key thing about frailty is that with this increasing both numbers of older adults and the increasing lifespan, more people are living to 90 and 100 years and beyond. There's an increasing expectation that there will be more frailty. And we need to think about that in order to better adapt and organize healthcare and psychosocial care for aging individuals. I think the healthy aging communities is one example of how we are looking at creating environments that people can age well across the age continuum. Because one of the other key ideas that I had early on was that frailty is not segregated to those over the age of 70 or even 80. And there are some in as recent as several years ago, I heard geriatricians say, well, if you won't find frailty you'll only find it in people over 70. You won't find it in younger, older adults. My thought on that is there is increasing research, including my own work, that shows that you'll find it if you look for it. And that frailty, of course, depending on how you define it, is detectable at a lower prevalence in middle-aged and older individuals. And this is internationally, as well as in the US. And the importance of that for me is considering how can we prevent or delay frailty? What are those factors that set people up for frailty? And how can we create living communities and preemptive interventions that can be embedded in our care practices officially and as well in our communities as a part of a social norm? And so in terms of significance in the community, depending on the frailty tool used, the prevalence will be about 4% in the young old and as much as 25% or greater in those over 85 years of age. In the hospital, these frailty prevalence rates can vary considerably from 25% to 97%. And again, depending on the measure, it is that there is significant issues with frailty that differentiate it from other measures of risk, such as comorbidity or even simply advanced age. Risk factors for frailty are in general looking at sedentary lifestyle in terms of low physical activity, poor nutrition, underweight or overweight, obesity, being female. Older age is a risk factor, but also minority groups and stressors that create cumulative dysregulation in body systems over time due to chronic stress. And so this frailty, I believe, is also a source of health disparities because of these cumulative effects of stressors. The presentation of frailty is perplexing, however. It is ambiguous in its manifestations. It can have an insidious onset. It can have a dynamic and fluctuating course, which implies that it is potentially reversible and treatable. Frailty is associated with numerous adverse outcomes, including hospitalization, losses in activity of daily living independence and disability, premature mortality, physical limitations, and falls and fractures. Nursing home admission, of course, is another one that goes hand in hand with decreased physical capabilities and other aspects of care issues that may require care beyond what the individual can receive from their family unit. Some theories of frailty include that frailty as a vulnerability to stressors, as a loss of complexity, as a disuse syndrome, and then due to homeostatic dysregulation. So what are the physiologic underpinnings of this? There can be a number. There can be the convergence of comorbidity and poor management of those comorbidities and lifestyle issues that impact on that, such as physical activity, nutrition, psychosocial health, and so forth, and the environment. So here are more comprehensive definitions of frailty: a complex multifactorial syndrome due to the cumulative effects of physiologic aberrations across multiple organ systems, cardiovascular, endocrine, neurohormonal, and so forth, and failed integrative responses to psychosocial stressors, both biopsychosocial stressors. This leads to a precarious state of poor health, poor compensatory reserve, resilience, and recovery to adverse health events, and ultimately those adverse outcomes. I like this slide because it shows sort of in a visual way how the bounce back works with frailty. So with an individual up at the top managing well with good biopsychosocial integrity, a response to a stressor such as a cold or the flu involves some acute response, a short recovery time, and a return to normal baseline. With mild frailty, or what they call pre-frailty, there is a more intense response to the stressor, a longer recovery, and a poorer return to function. There's never a full return to function. This area, I believe, is an extremely important part of hospitalization, where what's happening during hospitalization is potentially inflicting this compelling disability that comes from functional decline during hospitalization. There's a good deal of research now on the hazards of hospitalization and due to functional decline. People simply not being mobilized, not getting out of bed enough, so that by the time they go home, they've lost significant muscle strength and function. And then with frailty, outright frailty, you have a very poor response to the stimulus, to the adverse event, and then a very minimal improvement after that, and a further decline and increased dependence. And so some of the causes, we have talked about multiple organ system issues with decompensations that are not a singular organ system, but it's across systems. There are integrated coordination between systems, the hypothalamic, pituitary, adrenal axis, for example, which has a lot to do with our stress hormones. Chronic inflammation, a lot of our chronic conditions and our nutritional lack of good nutrition and physical activity, in addition to chronic conditions, increase an inflammatory environment in our body, which provides a favorable atmosphere for frailty. And then growth hormone issues and other impaired immunologic states. So there are a lot of different physiologic investigations into frailty, but it is not, there is no single understanding of what causes frailty, given its classification as a syndrome and it's multifactorial. There are many assessment tools for frailty. There are several commonly and widely used models. The first one is the biological model, the frailty phenotype. This was this was the first really well-validated frailty assessment tool to be made known and published. It defines frailty as a biologic syndrome of decreased reserve resulting from cumulative declines across multiple systems. And the features, the phenotypic features include unplanned weight loss, fatigue, slow walking speed, weak hand grip strength, and low physical activity. So some of these are these are all physical manifestations. So it's also called physical frailty. The accumulated deficit model, and the concept behind the biological model is that there's sort of this net effect of whatever is going on biologically is going to manifest itself in physical performance. One of the deficits of this model is the lack of the involvement of cognition and cognitive function. And so some of the iterations of this assessment tool have added in cognitive measures to capture that aspect of frailty. The accumulated deficit model, known as a frailty index, basically is determined based on the number and the accumulated burden of numerous deficits that are classified according to a couple of categories, such as activity of daily living function, comorbidities, some laboratory tests, and some psychosocial issues. A frailty index can be defined by between 30 and 70 deficits based on the literature, a minimum of 30. But what you'll see in the literature is anywhere from 10 to more than 70. And there's a real admixture of variables that are in there, or frailty deficits that are in the index. But the concept being, the more you have, the more likely, the closer you are to frailty. And the calculation of that would be by taking the number of frailty deficits present divided by the number that the total number that they are scored on. And it's a 0 to 1 number proportion. It would be a figure from 0 to 1. With the clinician judgment or subjective assessment aspect, here you would have basically the use of perhaps questionnaires and clinicians making judgments about physical performance. And I'll provide some examples here. So the reason that frailty tools have proliferated, there are more than 75 tools out there, is that frailty is poorly understood. There are different concepts that are used to create theoretical frameworks for frailty. And also it can be driven by what data you have access to. And so there is great variability. There is also an appreciation for the fact that there is likely to be no one perfect frailty tool for all applications in research and clinical practice, and that determining what the purposes of what you're doing is important, and to be sure that in your publications you define, particularly in your abstract, how you are defining frailty operationally, so that it can be clear to researchers and clinicians what frailty means. So here's an example of the measures for the frailty phenotype. So weakness is measured by grip strength, slowness is measured by walking speed, and in fact, walking speed is sometimes used and has been validated as an independent predictor of frailty in outcome studies. So just looking at timed walking, very important tool, very possible to implement in clinical practice, but you need training, you need equipment, and you need time to do it. Physical activity is measured by a questionnaire that people fill out. So here it's a subjective assessment. Exhaustion is measured by 2 items from the CISD depression scale that refer to having energy. And then weight loss of about unintentional weight loss would be the 5th. And so frailty of greater than 3 of these, a count of greater than 3 of these signals frailty. So here's an example of the deficit accumulation frailty index. And this would be a selection of the variables that were used in this study anyway. But what's interesting about it is that it includes comorbidities. And in fact, some of the shorter frailty indices that are maybe 11 or even 20 or 30, half of them will be comorbidity. So it leads one to question, well, is this really comorbidity or is it frailty? Um, the thing is that again, gets back to your purpose. If you're looking at a risk model to predict an adverse outcome, it's a different way of capturing information that refers to risk. And so it can be clinically useful in that regard. However, for the practical application in clinical practice for care planning, it may have limited utility because it's this kind of, it doesn't necessarily correlate or coalesce into meaningful use. The Frailty scale is a quick survey that's designed for clinical practice in primary care. And it asks the patient these 5 simple questions. So, are you fatigued? Can you climb a flight of stairs? Can you walk a block? Do you have greater than 5 illnesses? And have you had a loss of weight? And so this can be very helpful in clinical practice as a screen. And the idea of these, and I should say frailty screening assessment tools, because they really do spark the necessity, if they are positive or indicating frailty, that there be further assessment. Now, the clinical frailty scale is something used a lot more in acute care because it's a clinical judgment, and it can be embedded in clinical notes and probably in the electronic health record, but it does require someone that is somewhat geriatric minded, if you will, who understands function and can and work with this. And there is some training involved, but it can be deployed in practice to provide a subjective assessment. Again, here, I think this in contrast or in a similar vein to the frailty indices that have comorbidities in the list, this is all about physical function. And ADL function and disability aren't the same as frailty. And so there is some overlap, which I'll speak to there is some overlap in terms of frailty, comorbidity, and disability. And this was demonstrated well many years ago, 2004, by Linda Fried and colleagues, that the terms are often used interchangeably, or measures account for these similarly as frail. But you can see in this slide that that comorbidity, disability, and frailty are not, the Venn circles aren't covering each other totally. There is overlap, but they are not the same. Which, of course, in the aging process, the heterogeneity of older people and makes it difficult to untangle those issues. And so that is the challenge in the assessment. And with the idea, I think, of coming at it with a health promotion perspective to look at ways that you can maximize function in every way, maximize and medically optimize chronic disease management, and implement the kinds of interventions that can mitigate or prevent frailty, such as physical activity and nutritional and psychosocial interventions. So I'll be speaking about today just 2 studies that are most recent, based on the work that I've been doing here at UNCG since 2015, that focus on using the electronic health data from hospitalized older adults. And so my research has focused on looking at the existing data, looking at that treasure trove of information that exists in the hospital records. And when I first got this idea to look at frailty in the acute care setting, I thought, great, the electronic record is there. We can look and discover information that nurses and doctors and other providers are generating on a minute-to-minute basis. My original research for my dissertation in 2008-ish, 9, was at Duke, and looking at frailty in an EHR data set, which at that time, believe it or not, was pre-Epic. And so the electronic health record were basically PDFs of notes that were checked off by nurses and doctors, and documentation and reports. And I went through it by hand. My sample size for that study, which is the last one here with Dr. Wallace, Dr. McCoy et al., showed basically in this 278 patients that frailty was, we looked at readmission and we looked at mortality. And I thought, this is great. We have this data and we can deploy it in a way that's useful. When I came to UNCG and Epic, now that, some years later, and Epic is fully adopted in healthcare settings, I'm thinking, great, Now we can just Google what we need to do in the electronic health record and really maximize this data. I went to, meanwhile, went to a National Institute of Nursing Research boot camp on big data and data science to learn about how to work with EHR data and some of the big data issues and so forth. And much to my surprise and shock and dismay, it's not that easy. Developing a data set and building a data set takes years to actually curate and call the information. Places that are big medical centers that have entities that actually build that data set for you, they have a data repository already called, and you submit requests for what you want for your data pool. Here, instead, we pulled files flow sheet by flow sheet, lab test by lab test for our sample is like 77,000 patients and with many variables. So we had to identify how the electronic health record was structured in order to figure out how to pull all that data. That was been fun. My work in the qualitative literature has explored frailty. In particular, there's a study that I found very interesting. It's exploring frailty in African Americans living in the community. And this was done at one of our health centers in Greensboro. A lot of the literature is silent on how this subgroup views frailty. And what I learned from that in focus groups with African American adult men and women was that frailty is highly driven by your psychosocial, the meaning that you have in life, your spiritual kind of wholeness, your sense of hope. And that if you've lost your sense of hope, if you've lost your sense of self-efficacy and agency, that you devolve into frailty, that it's very much intertwined with psychosocial and spiritual function, as these are the main drivers of health and wellness. All of us here, I'm sure, would agree that that's not highly surprising, but it is not much in the literature. The literature is really driven by the medical model and these physical phenotypes and the tangible, tactical manifestations of frailty. But the underlying issues that are drivers of frailty are equally important in these areas of psychosocial function and spirituality. I've also been involved in doing some systematic reviews looking at the risk prediction modeling and in particular at readmission and the ways in which these models work so that I can kind of bring that to the table as I look at frailty. And so I'd like to acknowledge here my frailty study team here at UNCG. We have Dr. Tom McCoy, who is here on the left. He and I are more and more sharing a brain on frailty. And he's just a remarkable colleague and statistician and just highly imaginative, always thinking beyond the curve and thinking of ways we can really bring new science to this work. Dr. Marjorie Jenkins is my colleague at Cone Health. She is the Director of Nursing Research, and she and I have worked very closely to figure out how to make this EHR data, and a lot of it is going to be nursing data in our future work, really be brought to bear. Dr. Soumya Mohante and Dr. Prashanti Manda are my computer science colleagues, and so they have been extremely helpful in helping to look at different ways of modeling the electronic health record data, and we'll be hearing about that today. I'd also like to acknowledge two of the current research assistants, Riham Yazin and Ismail Olasaj. There have been others. These are the two that are currently working on this project. And so this first study, let me tell you very briefly, what we're looking at here is taking I developed a frailty risk score using EHR data that in the first data set, the Duke data set, included 16 frailty risk factors that included a variety of geriatric syndromes like fatigue, weakness, and shortness of breath. You'll see a list of those in a short moment, as well as biological markers that included lab tests, blood tests for things like hemoglobin and albumin that are linked to frailty. Abnormal values are linked to frailty. We wanted to look at, a lot of the risk prediction modeling to look at predicting who is rehospitalized. So we're looking here in this study at hospital readmission. we wanted to identify basically a risk model that would capture with good precision those individuals that were more likely to be readmitted within 30 days, which is considered a quality of care alarm. In other words, there are issues with early rehospitalization that get the attention of the Centers for Medicare and Medicaid Services through the Readmission Reduction Program, which has looked at reducing these readmissions um, and assessing financial penalties for those readmissions for certain medical diagnoses that are determined to be that were determined to be potentially preventable. So here we're looking at readmission in a couple of different ways. One is we're including frailty in a readmission model. Two, we're going to be looking at comorbidity, which is a list of chronic medical conditions, and there are several comorbidity indices out there. We looked at 3, and we compared several different frailty risk scores with different comorbidity indices to look, along with some other covariates, to look at 3, 7, and 30-day readmission. Why so many readmission outcomes? Well, there is evidence that earlier readmission after discharge within that 3 and 7-day window may be due to distinctly different factors than readmission later in that 30-day window. So we wanted to explore that. We weren't looking to identify what those were. We just wanted to know what the pattern was. And if those readmission, what were the characteristics of frailty and so forth for those earlier readmission individuals versus later. And then ultimately to identify of all these models, 5 different frailty risk scores combined with 3 different comorbidity indices plus covariates. Among those, what is the best model for predicting readmission? So this was a secondary analysis retrospective data, EHR data for 5 years. And we looked at demographic data, clinical data, as well as we used ICD-10 medical diagnosis classification codes to map the frailty risk score. We looked at medication data and then serum lab values. The analyses we used for this first study was we used classical statistical analyses using multivariable logistic regression and then testing the accuracy with the AUC. In the second paper I'll talk about, we used this same data set, but we looked at readmission, 30-day readmission using machine learning models. And so I'll be telling you more about that shortly. So our methods here, I'll just mention that, didn't I just say that? Oh yeah, I meant to cut that slide. So here's the 2 studies that I'll be speaking about. So the first one is comparison of the frailty risk score and the comorbidity indices, and then the multimodal machine learning. I think that got out of order. All right, so here I've mentioned about the reason that we're interested in readmission, because it's a modifiable situation that can benefit hospitals. Readmissions are bad for the hospital bottom line. It's also bad for patients because every readmission exerts a negative toll on the patient. And a readmission may signal either quality of care issues that occurred during hospitalization that rendered them less medically optimized and ready to go home. So it could be any kind of the care received. It could be the discharge planning process. It could be the transitions in care process as well. It could also mean the lack of the patient's social structures to be able to manage what they need to manage in the home or in their setting. And we know that of the 20% or so of the Medicare patients that are readmitted within 30 days, at least 12% are avoidable. And as small of a number as that is, that it equates to a huge financial impact. This is our study flow chart. I'll just summarize this by saying that our exclusions were, the data set included people who were 50 years and older to capture those early frailty folk. We looked at that 30-day follow-up. They had to have an index admission and a readmission. But someone who may have had, like there was one patient that had 104 admissions, independent admissions after that index admission. We only went for that first 30-day because of the concept and statistics of the repeat measures design. So Many studies use only the index admission and not all of the other one. The index admission and then that first readmit. And if that first readmit was not within 30 days, then it would be yes 30 days, no 30 days. And of course, those who died were excluded. The frailty risk score is based on a biopsychosocial spiritual model, considering symptoms and biomarkers. In this study, the frailty risk score was mapped from the original one that I described to you, the 16-item one. We were able, with the electronic health record, to add some frailty risk score variables based on the literature and based on, over time, my learnings and understanding of frailty. And we also looked at using both lab data for blood biomarkers as well as ICD codes that would be proxies for the lab data. So, for example, for hemoglobin, that would be abnormal. A low hemoglobin would be anemia as the ICD-10 code. And so that's how we worked with the lab variables. This is an at-a-glance conceptual model, and I don't know if you all get excited about conceptual models, but I do. But this kind of basically at a glance tells us that with age, with the accumulated stress, there are points here of intervention that can be employed to prevent, mitigate, or delay frailty. But this is conveying a frailty trajectory that increases over time. It signals the interconnectedness of the biological, psychological, social, and spiritual. And then it looks at the frailty correlates or risk factors, and then adverse outcomes. So here are the 5 frailty risk scores. Don't go dizzy. What I can break it down for you here is that you have the frailty risk factors on the left are very familiar syndromes, geriatric syndromes. Weight, abnormal weight, as I said, high weight, low weight, malnutrition, weakness, fatigue, dyspnea, chronic pain, smoking, vision problems, urinary incontinence, falls, delirium, depression, dementia, social support issues such as living alone, not having, needing a caregiver but not having one, and then material resources, which has to do with having sufficient housing, food and safety measures and so forth. And these were added because of availability in the electronic health record of this data. Now, that doesn't mean the data were coded if they existed for the patient. So one of the caveats with this ICD-10 data is that undercoding is a big problem across, the EHR, but even more so for the more soft situations such as social support, material resources, and some of the other, even things like depression. There can be an undercoding. And so, for example, studies have shown that when looking at the EHR, you will, ICD codes plus the medication list will give you a greater number of, a presence of depression. So if you're on an antidepressant, that's probably a good sign that you're, except for maybe one class of antidepressant that's indicated for other things than depression. But there are limitations with the coding. So there are different definitions here, different operationalizations of the frailty score. We've added in dysphagia, swallowing difficulty walking, fecal incontinence, and then pressure ulcers or decubitus ulcers. And then the biomarkers include albumin, creatinine, glucose, hemoglobin, sodium, white blood cell count, and then C-reactive protein. The problem we had with biomarkers is that, in contrast to even maybe 5 years later, nowadays there are great disincentives to ordering blood work panels. And so some of our patients had none of this blood work. They had no hemoglobin, no sodium, which are considered part of a basic panel. So it was very interesting that we couldn't get lab data on all of our subjects. And so you can see the FRS, the frailty risk score 18, lab biomarkers. You can see that there are some here that we couldn't get. I mean, our sample size dropped from 55,000 to 30,000 in order to deal with the sample size. And we elected to include only those that had, some that had the blood work and whether it was abnormal or normal versus having everybody in. So we had up to 26 frailty indicators, and of those, 19 were potential maximum total of 19 were the geriatric syndromes, and then 7 were the blood biomarkers. Just to make it, so regarding data acquisition, this has been quite challenging, but exciting. We, we're really had to spend a good deal of time trying to figure out where the data were, how they were nested, because everything is sort of stacked in different types of assessments and so forth. But for some of our clinical data, so that's been challenging. We had issues with computing power and storage, needing more storage and processing space and so forth. So we needed more funding, which we were able to get through some grant writing and internal grant funds. So that has been much appreciated and helpful in this work. We've had tremendous support from UNCG through channels, and that has helped keep this work moving forward. Here is a list of the data elements. What's the usual demographic data is here, but what is also in here that is important and is considered to be a part of what is called claims or administrative data, used in many risk prediction models that don't even get deep into the EHR. It's just the claims data, is that the principal, whether the admission was urgent, what the principal problem was, the reason for admission, what their secondary medical diagnoses were, that would be their comorbidities, and then looking at insurance payer, their time of discharge, their discharge disposition, where they went, where they were admitted from, their admission location, and those are very commonly used in readmission risk models. We were able to develop 3 comorbidity indices. The Charlson Comorbidity Index is well known, used extensively. There are 2 versions. One is 12 items and the other is 17. So we decided in this study to put them head to head, in addition to the Elix-Hauser Comorbidity Index, which is a 29 or 30 item index. The 5 frailty definitions then were the frailty measures. So those are the data elements in the model. And our analyses, as I said, we had a total of 45 models considering the 5 frailty definitions, the 3 comorbidity indices, and the 3-day, 7-day, and 30-day readmission. This is so exciting. Here's an at-a-glance look at our sample. Average age is 69, mostly female. We had pretty good representation of African American, 23%. Most were married, 20% lived alone. I was kind of surprised. Medicare was 50%, Medicaid 4%. Emergent admissions were almost 60%. Most were admitted from home. And then we see some numbers with the different, the length of stay was 4, 26.9% were readmitted within 30 days. And then the frailty risk score ranged from 1 to 4 frailty risks, risk factors as a mean, with the standard deviation, as you see there, 1.5 or 2.1 respectively. And then the comorbidity indices varied as well. And so I'm going to skip that. Here is the summary of the frailty risk indicators. You can see here that the most prevalent was dyspnea and abnormal weight. And this is likely to be tipped by obesity as it is to underweight. The most common biomarker was, I believe that's saying hemoglobin, anemia. And so we see, and then here we see depression is 13%. Smoking is 13%. Weakness is 10%. Fatigue is 6.3%. Yes. So we have a picture here of the frailty risk factors. I was surprised at how low the prevalence was, because in the original study where we had the frailty risk score computed from nurses' note data and physician data for all of these syndromes, the average score, the frailty cut point was 9 of 16 risk factors. So here we see a much lower prevalence, but nevertheless, we were still able to model this. It is kind of the factors to consider in interpreting the data and understanding how, using the ICD-10 codes for this purpose. Here's a beautiful graphic that Dr. McCoy did for our readmission outcomes for all of the 15 models here. So here we have the gray line is comorbidity and the black line is frailty. And the number 1, 2, 3 through 15 are the combinations of frailty, 20, for the 5 frailties and then the 3 comorbidity indices. What we see here is that these are the odds ratios. And so we have pretty reasonable odds ratios, but at a glance, what we see is that in general, comorbidity does a pretty good job with adjust for the odds of readmission. And several of the frailty risk scores do better than others. And that's remembering that some have the lab blood tests and the others have ICD codes that would need to be coded, that physician would have had to identify that there was a problem with the lab, such as anemia or low sodium or high sodium and so forth. And so here we have the AUC, or the accuracy, sensitivity of the measures. And so we're seeing for 30-day, for early readmission, we have a bit higher accuracy for frailty and comorbidity combined. So here on the right, you'll see 1 through 15 are the 15 different models. And you can see they're all pretty close. I mean, the difference between a point here on the second 7-day between a 0.80 and a 0.81 is pretty small, but we can see that they all perform similarly well. And those, let me say, are really good AUCs for readmission. In general, readmission models are hovering in the 0.6 to 0.8. And in our first study, the Duke study, it was a 0.68, I think it was. So these are really quite good, given the limitations of the data. It's telling us that, we have some pretty good sensitivity here in being able to differentiate someone who has a higher risk for hospital readmission at these 3 time points. So the study conclusion is that frailty at first admission is predictive of increased odds of 30-day readmission. The Elix-Hauser comorbidity tends to do a bit better than Charlson, but they all the comorbidity, all 3 comorbidity indices do pretty well. The best model for the AUCs were the FRS 26 and ECI, the Elix-Hauser combination for earlier readmission, and the Frailty 26 Charlson comorbidity 12 combination for the 30-day readmission. These AUCs are good, but there's always room for improvement to improve precision. We limited the number of variables in our model to, we'll see in the next version with the machine learning when putting more models that can be interesting, but these variables were seen as the most salient for what we were interested in. So here we have the second study, which is the multimodal machine learning approach for predicting readmission. And this, the research question here was to look at using machine models to use a wide variety of EHR data to predict 30-day readmission in hospitalized older adults and to identify the most important factors that predict readmission. So we'll be looking at the features that are associated with readmission. So machine learning is basically how machines learn about and make predictions based on data. It takes a bit of a different approach than classical statistics. It involves a variety of applications of complex statistical formulas, such as statistical modeling and machine learning algorithms. Here we use supervised learning procedures with features extracted from the electronic health record. Those would be the variables. And the outcome was labeled as readmission and no readmission. In this particular analysis, we took the approach of, instead of just the one index admission, the first admission or index admission, and then a second, the first 2 only, this included all admissions, but it was geared toward the first admission And then the next 30-day admission, if there was a second admission that was within 30 days, that was captured in that dyad. Then after that, there'd be the next admission would be that next index admission. And then it goes on from there. So we have more observations, but there are, you know, statistically, there are issues with multiple comparisons across that same patient for all of those admissions that would be accounted for in the types of analyses that are being done to to address those multiple comparison issues. We looked at comparing models, the linear model, we used linear regression, and then the ensemble models for machine learning, random forests, XGBoost, and CatBoost. And these are decision tree algorithms. They're very cool. They look at classifying the variables in different ways by running different combinations in different algorithms and based on different predictive rules. And there are different ways of doing that. And those are the 3 models that were used here in this study. And I'll be, and then we'll be looking at some of these performance outcomes. I'll be particularly looking at AUC. Here we have our data set was 76,000. The analytic data set was 68,000 patients, 122,000 hospitalizations, and then the number of readmissions at 30 days was 18,000. There were 369 variables in this model in comparison to about 50 in the model that we just talked about. And in general, they were these general categories. So demographics, we used just one frailty risk score. We used just the Elix-Hauser Comorbidity Index for comorbidity, as well as the number of comorbidities and individual comorbidities. And they all, in the way the models work, capture where the connections are and where the strengths are in the modeling. We looked at the disease diagnosis in addition to the comorbidities. So the ICD-10 classification areas are the category codes. So there would be respiratory, there'd be neuro, there'd be cardiovascular, those kinds of things. And then different from our first study, because we've just finished this most recently, is high-risk medications. And so you all are familiar, I'm sure, with the Beers list, which has categories of high-risk meds that should be avoided or used with a caution in older people. And so we looked at 10 categories from Beers list, and then we had some polypharmacy variables. Very exciting. So here's our algorithm, our study flow chart. And so our analyses started with looking at segmenting the data to do sampling. And so there's a developmental data set to train the models on the data, and then the validation data set to go ahead and operationalize the models. And so there was the modeling with logistic regression, and then these are some descriptions of random forest, XGBoost, and CatBoost. And so here are the results. Here we have the blue line, which is random chance. This is the 50-50 toss a coin. And we see that logistic regression is the pink. We have CatBoost is the orange, and the XGBoost was green. And the random forest is the other orange. It is CatBoost.
Oh, I'm sorry to interrupt. We have a question in the chat thread from Susan. Where are you, Susan? Is your
I'm in Chapel Hill.
Oh, I meant where you were on the screen. Yes. Good to know you, Chapel Hill. Do you want to ask your question yourself?
Happily. I didn't mean to interrupt, though. This is
a
wonderful presentation, but there's been some good evidence that hospitals that increase their use of occupational therapy for inpatients, for people with pulmonary and cardiac and some other conditions, have reduced their 30-day readmissions. And I was wondering if that was part of your tracking process. Thank you.
That is one of the caveats of this study. You know, we really were looking at the readmission outcomes, but we have not looked at the factors that looking at those that not only were readmitted, but those who were not readmitted. And in fact, we did another sub-study. Actually, I didn't put it in my list because I just submitted the paper last week, but we looked at the behavioral health hospital and the 1,063 patients there to see, you know, about readmission, and their readmission was very low. And it's like, well, you know, there's some insights that you want to gain from what it is that you can do to prevent the readmission, but you also want to look at what works and what are those features that contribute to the lower readmission rate among a high risk group. If, for example, they are frail or they have the COPD, which is one of those quality indicators that readmission is penalized if they are determined to be preventable. Yeah, you want to look at those programs that that are developed to be tailored both at the individual level and then from the population health perspective. What kind of baseline kind of program do you want to have in place? But absolutely, the interprofessional collaboration and communication, you know, this kind of information would generate the next steps to identify where to go from here. But yeah, most of the readmission research doesn't get into that as much. I don't know that I've included the citations in this particular presentation on the kind of that research, but I'm happy to add those in. Thank you. Is that answering your question?
Yes, I can. You probably have seen this article about readmissions. If not, I'll just send it along. But
oh, good.
Thank
Perfect.
you. Thanks. This is a wonderful presentation.
Thank you. Super. Any other questions? Take a deep breath. I'm mindful of our time because I believe we're ending sometime before 2, right?
Right.
Yes.
Yeah, I did want to ask you, you don't have to do this now, but before we separate today, I was wondering if you had any thoughts of how you might in the future use similar data to study the impact that COVID has had on frailty and perhaps readmission. But it seems to me that a lot of the variables and the you know, all the indices that you reviewed could be affected by the need to stay at home. So
absolutely. Yes. Yes.
maybe you can just
Oh my goodness. Yes. The whole, I totally hear what you're saying, Rebecca, about the impact of COVID being an actual kind of this potent, you know, instigator for frailty because people can't be physically active. They can't sometimes get food. They can't go to the nutrition sites. They can't get to the grocery store. Their family can't get the food to them as regularly as possible. The psychosocial aspects that diminishes their sense of drive and empowerment and self-efficacy to do the things they normally would do to take care of themselves. There's been a lot, as you know, in the frailty, in the gerontology literature about this compelling kind of surge of frailty that will be a secondary consequence of that. You know, one of the things that Cone Health is doing is they are, you know, like many hospitals, they've since I've started this research, they have developed a huge kind of team of IT people who are doing this kind of risk modeling, and they're very interested in the work we're doing, but they also are doing some very high-powered things that are in real time. We're creating the model based on retrospective data, but we're hoping that what we learn from this can be tooled into clinical decision support resources, you know, different algorithms that can be hardwired into the electronic health record, different dashboards that could be installed that, you know, will alert, you know, that's different than a medication alert because, you know, nurses and doctors are kind of saturated with alerts and they have what's called alarm fatigue. But could there be a way that somehow it helps to stratify patients so that nurses can sort of save their energy, if you will, for the more nurse intensive needing patients versus those who can receive more usual nursing care. And the nurse intensive might require more collaboration with interprofessional colleagues because the nurse at the bedside is going to see firsthand what the potential needs are, and the imperative of reaching out and getting in place pronto the kinds of supports that can help them in the hospital as well as for that care transition home and or wherever they're going. Indeed, yeah, thank you. So here we see then so here so the AUC is actually in the right-hand corner down here. I guess I'll go back to this machine learning model. You'll see that they're very good. They're between 7.8 to 8.80. The logistic regression was not as high, but from this model, it's showing that Cat Boost was the preferred or the premier machine learning model. And what is interesting though is like, okay, so that's great, but what does it tell us? Well, here you've got the top 50 features of how many did I say? Like 389 of the variables. And so it's all of that, but in the machine learning modeling, that is all worked out in those trees. But what's interesting is how we're seeing here the same kinds of predictors that we saw in our model, which is we had the Elixhauser was the best performing model, and the Frailty Risk score 26 was what we chose those, but they actually they're showing as a stronger, among the stronger features. So this would be the top 20 out of almost 400 variables. I've color coded them. So here we have frailty in red, comorbidity is in blue. So we see that not only the Elixhauser index, but other comorbidity variables. So number of diagnoses, number of unique diagnoses, that would be the individual name like heart failure. The ICD-10 code, that was those 19 categories of ICD-10s that it's another level of collapsing. And then we have the individual ICD-10 for musculoskeletal. So these were the top 20. These indicate they're a stronger driver or a stronger feature of the readmission. Length of stay was a strong feature. The discharge disposition to a rehab facility kind of blew us out because it's number 2. And look at the line up here. It's a very strong feature. Well, the reason for this is that there were, I believe, less than 1,000, something like 989 patients who were readmitted to a rehab facility. And nearly all of, that had a discharge to a rehab facility, but nearly all of them were readmitted. So whatever was going on, we don't know what those factors are. So Susan, to your point, this would be a trigger where we would want to explore why the readmissions why a discharge to a rehab facility was considered, why that was such a driver. I should back up, and I think I may have been unclear. The data set for the health system included 5 hospitals. And so there was 5 different hospitals. And this is a discharge to a rehab facility, which would be not a nursing home, but a facility that is designed for rehabilitation patients and has different, and different criteria. The discharge disposition to a short-term hospital also was a strong feature, as well as discharge to a psych hospital or to hospice. Okay, so those are, again, we have to determine what the meaning of these are, but this is what is driving this result. And then the green would be the high-risk medications. So this construct, the high-risk medications, was not in our first study. So this was interesting, but look at how many high-risk medication categories are in the top 20. I mean, there's 5 of them there. So we see that from a clinical standpoint, these medications are not, it's not that they are causing readmission, but these are medicines that these folks are on that for those people who are readmitted. And so it makes, again, these are drugs that should be used with caution or avoided if possible. And we know that polypharmacy is a big issue with older adults. And so here's, again, a cue to pay attention to that. The other variables that are on the list on the left of the 50 that are featured here include quite a few of the frailty risk factors, the individual risk factors. So they were included in the model in addition to this total score, the FRS 26, the individual risk factors were included because it was, the concept is that none of them individually would conflict or drive the score of the combined total score of the Frailty Risk Score 26 ICD. And so those are there. We also see that that included the syndromes, as well as we see sodium, which is the abnormal sodium. That would be hyponatremia, hypernatremia, high or low. So that would be one of our blood biomarkers. So a lot of the individual frailty risk factors were also featured in the top 50. So what do we know? What do we understand this far? We see good synergy in the findings between the two models. The AUC precision is greater for the CAT boost for the machine learning model, but we can't make that, it's not really equal because the high risk medications were included in that model, and those need to be studied further in the model that we did with the first study, the linear regression model. Comorbidity and frailty are influential at readmission risk, and frailty does add new information to the model that can help perhaps identify those high risk people, and that the models that included our frailty risk score had better performance than most other risk models in the literature. Limitations, we're all very familiar with limitations of secondary data that's collected for other purposes. It's observational, it's not a cause and effect, cannot be assumed. There are potential coding practices that may limit the coding of certain things or undercoding. We've had sample size loss with the inclusion of the biomarkers, so we need to explore that further in larger data sets. Our study was limited to one region in the United States, and as we just talked about a moment ago, the readmission to other hospitals was not tracked, nor were the reasons for readmission and determining the preventability of those readmissions. So some studies use some software to determine whether readmissions could be prevented. That was not a part of this study. Future research, this is what we're working on now. This is very exciting. This is more painstaking because what we're doing, and we've just completed, the tedious task of pulling individual flow sheet data from the nursing documentation, mostly, and some from physical therapy, occupational therapy, and dietary for some of the parameters that they use in the assessment. So we have a much richer data set. We're just now mapping all of the different flow sheets that would correlate with the different frailty risk factors. And Dr. McCoy is in the process of building a new frailty risk score that we'll be able to examine in this data set. And then this would then spark the next step, which is doing some further testing and validation. And if we see promise, then looking at IT innovations to build clinical decision support tools and dashboards, as we mentioned before, for frailty alerts. But also we can use frailty to identify acuity level of patients on a unit and determine the types of nursing personnel that would need to be there in place, their qualifications, the numbers, and so forth. It can guide in care planning, both individualized as well as program planning for population health. This would be done at the hospital level, but it's also being done at the community level, looking at frailty as a way to identify high-risk vulnerable elders in the community that might need assistance for programming for health and wellness on a daily basis, but also during crisis and disasters, and who in the mapping is in an area where there are clusters of people that are highly vulnerable. And then looking at a systems approach to mitigate the hazards of hospitalizations that provoke frailty. Unnecessary bed rest and restraints are a huge thing. People kept in bed for observation, but for really no good reason. Unless they're hemorrhaging and have almost zero vital signs, they shouldn't be on bed rest. That occurs is truly significant, and it occurs on the second day, like somewhere between 10% of muscle strength per day starting on day 2 or day 3 occurs. And in older people, it's much harder to regain that back. Prolonged periods of restricted fluid in foods, people waiting for tests and so forth, has a detrimental effect on the body. Polypharmacy, over medication, using sleeping medications unnecessarily when we should really be paying attention to the environment and helping people get better sleep. But disrupted sleep is certainly a component of contributing to the sleep deprivation and to the development of delirium. So delirium, preventing delirium is an important aspect of hospitalization and frailty, and as well promoting toileting to prevent incontinence. These are preventable issues that require just basic nursing care and the sufficient staff to implement that. And here are our references. Are there any questions?
There was, she may have had to leave. There was Ellen, did you want to say something? I see you posted. Ellen, oh, wait a minute. Ellen, you have to unmute yourself. Oh, wait a minute. Here, I'll do it.
I think I lost my screen. Here we are.
Can you, there.
I just wanted to put a plug in for PACE programs. If you're not familiar with those are programs of all-inclusive care for the elderly. They provide care for people 55 and older who have identified frailty. They work with an interdisciplinary team of 11 disciplines to keep them functional and high quality of life and keep them out of the hospital. When they do go to a hospital, the team reassesses and figures out which domain needs more tweaking and puts it back in place. We've had some real dramatic reductions in people who had been chronic hospital repeaters prior to coming to PACE, who had dramatic reductions in hospitalizations after that. So if there's a PACE program here in Greensboro that serves Guilford and Rockingham counties, if you're not in this area, I put a website on the chat line that you can go to for more information.
And then also, Connie, are you still here? Connie Morse? Would you like to say something about the program you were discussing in chat?
I think that Connie Morse's first comment in chat indicates, it says only have chat, no mic. So Connie may not be able to say anything.
Right. Okay. Well, let me read what she put in chat then. I forgot she was the one who had done that. Okay. Sorry about that, Connie. She said, Piedmont Triad Council of Governments, it has to do with the Healthy Opportunities Social Determinants pilot program. We've been involved since 2018. COVID has put a kick in the process like everything else. She said if you want more information, they can contact her by calling. She has her address in there, but she said also you can call PTRC directly and speak with Bob Cleveland about the process and where we stand. So I think she was seeing a connection between your research on frailty and the program that they're doing there at PTRC.
It's so crucial. The community supports, it's all connected. And, the biggest thing is the transitions in care and not letting those things drop off the map. And, the importance of having, a care plan in place that has the key entities involved, to have a direct plan for medication monitoring and for symptom monitoring too, because when people start doing poorly, it's usually very insidious, and it takes time as little things start to change. And if nobody's really tracking that, a week or two can go by, and by then there can be a cascade of really adverse effects.
Connie posts further. We also have found that poor discharge planning was a factor. Sending someone home without a caregiver identified, clear instructions, making sure they had someone to fix meals, change dressings, make sure meds are available, taken on time and correctly, etc. In the Triad area, we are currently in the process of working with hospitals to contract with community partners such as Meals on Wheels, in-home aid programs, transportation, adult daycare, et cetera, to try to help alleviate this. So if folks on the call want more information, they can contact her or call Bob Cleveland at PTRC. Thank you, Connie. Sorry your mic doesn't work. I'm sure that you and Deb could then have a dialogue. Perhaps it can take place off screen. Are there any more questions? We have just a few more minutes. I just want to remind everyone that one of the main reasons that we have these growth lunch and learns is to help people connect, either on research or service or even teaching, and so if this research that Deb has presented has inspired you in some way to think about your own research or service or teaching, be sure to get in touch with her, or you can always email me. Is there anyone here who, well, first let me thank Deb. Let's give her a round of Zoom applause. I guess we all have our mics muted, so it's not a resounding applause. It was really very, very interesting, and I loved your creative use of already existing data and appreciated all the challenges you had in making it usable as well. I'm wondering if there's anyone here who would like to mention a collaborative opportunity or to communicate with the other people who are on this Zoom room in some way while you have the chance. Guess not. Okay, Deb, do you have anything else you'd like to ask the group or to add?
I guess I'm curious about how people are managing older adult situations with COVID, given the challenges. And since we all have a special interest and are all really, really, really worried and distressed and feel like we're just on the edge of a cliff, and so many older adults are falling off the cliff. They're not probably doing very well with all of this. And so I'm wondering what kinds of stories or examples or situations are glimmers of positivity or proactivity.
I'll share that PACE of the Triad. That's been another advantage to our participants of being part of the PACE team. We still have 11 professional disciplines involved with every one of our participants. Some of them have stepped up, and everybody gets a weekly call from some discipline. Some of them get, all of them have been in for, not been in, but we've done telehealth reassessments every 6 months on them continuously, which is our process, and that's continued even with COVID. The biggest change for them has been our day center closed for a period of time and now is reopened, but at a much smaller capacity. So we've had to be very creative in sending out activity packets and doing virtual activities with people, virtual exercise programs. We've increased home visits as well. So our participants are missing each other, but they're not missing the PACE staff because we've been very involved, but it's been very helpful to them.
That's awesome.
I'm wondering, this is a little bit off the subject you were asking about, but I really, the whole time you were presenting was thinking about how COVID would change the data. And, you know, I'm also wondering about whether readmission is suppressed because, you know, caregivers might be inclined to keep people at home even when they would normally have, you know, sent them to the hospital, you know, trying to avoid, you know, contact with COVID. I mean, I just think that the data collected this year will retrospectively be extremely interesting. I mean, I can see both the dependent variables and the independent variables being artificially, not artificially, but being changed in response to the COVID context. So this raises some interesting hypotheses.
Well, I think too, as we get into a crisis with healthcare utilization and bed, you know, lack of beds available for people with or without COVID, people having other acute illness and acute conditions, stroke, heart attack, uncertain, you know, they need to be worked up. They're going to look at, you know, a rationing. There'll be kind of the emergency kind of strategy, which is if everybody can't get care, how do you stratify that, you know? And certainly I think age is going to enter into a big picture in comorbidity as one of the boom off the top. You know, I think there's our ageism propensity in society may really be brought to full force when there are limited resources and you've got a 30-year-old, a 20-year-old with COVID and an 85-year-old that has, you know, some other condition. It's going to be tough.
It's been flabbergasting to me how COVID has affected perceptions of older age. It's probably the most, well, it's something I've been thinking a lot about. My students who are, many of them who work in healthcare settings have, you know, brought back stories of exactly what you're talking about, of, you know, prioritizing care based on age. So it'll be interesting to see how this plays out. Well, a lot of people seem to have more Zoom meetings at 2, myself included. So I just want to thank you again, Deb. I want to thank you all. Send us gerontology students for our undergraduate minor, our post-bac, and also for our master's program. And we'll see you at the next session.
Thank you again.
Yes.
Have a great day, everybody.